Without further ado, let's kick off our conference with the first session by welcoming our chairpersons, Dr. Govind Makharia, Dr. Sameer Shah, Dr. Sujit Jagirdar, Dr. Chetan Bhatt, and Dr. Preeti Chabria. I request the chairpersons to please introduce the speakers.
So very good afternoon. In the first session of Build 3, and we had a wonderful meeting on APASL Singleton. So on behalf of all the co-chairpersons, may I invite the first speaker to speak on Dr. Jacob George to speak on glucose homeostasis in fatty liver disease. Jacob George from Australia.
So thank you very much again for inviting me to talk to this wonderful conference in this wonderful city. And I've been given by Akash a difficult topic, glucose metabolism in a steatotic liver and its implications for management. And I guess if I can just summarize the three main points of my talk. Firstly, the underlying pathophysiology of fatty liver disease is insulin resistance. Secondly, that the drivers of inflammation and fibrosis in fatty liver disease is related to adipose tissue insulin resistance and also hepatic glucose, increased hepatic glucose production from hepatic insulin resistance. So the underlying concept of MAFLD is reduced insulin resistance, and as all of you know, it's reduced sensitivity to insulin with a compensatory increase in beta cell production of insulin. It's fundamental to the pathogenesis of type 2 diabetes, and as you know, it's part of the metabolic syndrome that's got various definitions. Now, this is a paper that we wrote now 23 years ago that set the scene. This is the first paper, in fact, that in the liver literature mentions HOMA-IR. The second thing is it's the first paper to highlight that insulin resistance is key to the pathophysiology of MAFLD. And what we were able to show is that 98% of people with steatohepatitis had insulin resistance, and a full 87% fulfilled the criteria for the metabolic syndrome. The implication of this is that insulin resistance is universal in metabolic steatohepatitis. If you have no insulin resistance, you don't get MASH. And so the treatment of MASH has to do with reversing insulin resistance. So just trying to show you the bedrock on which this disease develops. At the bottom, you'll see at the very bottom of the slide, it's excess adiposity. Then you get dysfunctional adipose tissue and adipose tissue inflammation. And then you get all those other preclinical sequelae, including MAFLD or NAFLD, and then you get the clinical sequelae, dyslipidemia, hypertension, hyperlipidemia, hyperinsulinemia, and type 2 diabetes. So when you look at this slide, you can really understand why steatosis is not a predictor of cardiovascular disease, because it happens so early, and the clinical manifestations that finally drives cardiovascular disease are up the top end, even though at the bedrock, it is hepatic steatosis and adipose tissue dysfunction. So this is looking at the pathophysiology of type 2 diabetes and MAFLD, and I'll just take a little bit of time to go through this slide. You eat extra calories than what you need, and the extra calories are stored in your adipocytes, which increase in size, and when they increase in size and they can't hold any more, you get apoptosis and macrophage infiltration into the adipose tissue. With that, you develop adipose tissue insulin resistance and a failure to suppress lipolysis. The excess free fatty acids goes into muscle, giving you muscle insulin resistance. Some of that goes into the pancreas to give you pancreatic lipotoxicity. And the pancreas, in response to insulin resistance, produces more glucose. And some of the free fatty acids goes into the liver to give you triglycerides. And you also get de novo lipogenesis, and you get gluconeogenesis from hepatic insulin resistance. So there's increased hepatic glucose output. So there is very much a close relationship between MASH and type 2 diabetes. And typically we think of things based on the left side and the right side. We think type 2 diabetes is all about glucotoxicity. And on the left side, we think that MAFLD is all about lipotoxicity. But I'd like to show you that it's actually both lipotoxicity and glucotoxicity. But the lipotoxicity that drives inflammation is in adipose, and the glucotoxicity is in the liver, and it also drives inflammation and fibrosis. Now, we've got very, very good pathophysiological tools to measure all of this. So if you're looking at the glucose side of the equation, what you can see is you can measure glucose production in the liver by using radiolabeled glucose. You can measure glucose disposal in muscle by using radiolabeled glucose. And at the bottom, you can look at the fat side of the equation, where insulin resistance can drive increased muscle catabolism, and you can do it by radiolabeled amino acids. And then you can look at radiolabeled free fatty acids, and you can also look at gluconeogenesis and lipogenesis with double label water studies. So you've got the capacity now to separate adipose, liver, and peripheral muscle insulin resistance. This looks like a complicated slide, but in actual fact, it's very simple. It looks at adipose insulin resistance, hepatocyte insulin resistance, and muscle insulin sensitivity. In each of those columns, the empty box color is if you have low liver triglyceride and low VAT, and the red is when you have high intrahepatic triglyceride and high VAT. And as you can see, as you go from low liver triglyceride and low VAT to high triglyceride and high VAT, you get increases in adipose tissue insulin resistance, increases in hepatic insulin resistance, and reductions in muscle insulin sensitivity. So is MAFLD all about lipid metabolism? The first thing we know is that it cannot be that, because we know that individuals with MAFLD have fasting hypoglycemia, and they also have hepatic insulin resistance. And you measure hepatic insulin resistance by looking at hepatic glucose output. The second part is we know that MAFLD is associated with double the risk of type 2 diabetes. So how does glucose come into play? So the first thing is when you have adipocyte and muscle insulin resistance, the pancreas produces more insulin, but in the liver, what you find is that you get reduced insulin clearance. So again, you get a double whammy with increased insulin production or increased insulin in the circulation. And then what you have is, because you've got decreased insulin resistance in a steatotic liver, you get increased gluconeogenesis, and you get increased glucose concentrations. So hyperglycemia and hyperinsulinemia are common in this disease. So these are some very nice, elegant studies done by Amalia Castaldelli from Italy, and she looked at hepatic insulin resistance as measured by hepatic glucose production. And she looked at patients with simple steatosis, F0, F1 fibrosis, F2 going all the way to pre-bridging fibrosis and cirrhosis. And you can see that hepatic glucose production increases with increasing liver disease severity, and there's also increased blood glucose, and there's also increased blood insulin levels, as you would predict. Exactly the same when you try and look at the increased hepatic insulin resistance and the increased hepatic glucose production, and you say, what histological features does it correlate with? And you see on the left-hand side, the increased hepatic glucose production, hepatic insulin resistance, correlates with fibrosis and the activity score, but importantly, not with steatosis. Steatosis is what you see, the triglyceride that you see down the microscope. And in the transcriptomic cohort, you see exactly the same thing. Hepatic insulin resistance associates with fibrosis and activity, histological inflammation, but not with hepatic steatosis. So then it comes down to the question, what actually drives inflammation and fibrosis? Is it hepatic triglyceride, or is it actually something else? And so this is a very large study looking at about 350 patients, and they did clamps and magnetic resonance spectroscopy. And if you look at the slide on the bottom left-hand side, which says liver, and on the circle dots referred to the liver triglyceride. And you can see the liver triglyceride going steadily up, but there's no increase in hepatic glucose production. So hepatic triglyceride deposition is not correlated to hepatic insulin resistance. And on the right-hand side, once your liver lipid increases to about 6%, you don't get any further increases in skeletal muscle insulin sensitivity. But what does correlate with liver fat, what drives liver fat, is actually adipose tissue insulin sensitivity. So as you can see in this slide on the black dots, as the liver triglyceride increases, your adipose tissue insulin sensitivity decreases. In other words, the adipose tissue insulin resistance increases. So what we're really saying is that liver fat correlates best with adipose tissue insulin resistance. Now, does that liver fat relate to inflammation and fibrosis? And you can see that in Amalia's data, it says it doesn't. And so when you look at this big 350 people cohort, again, there is no relationship between liver fat and inflammation, ballooning, or even fibrosis. So if it's not liver triglyceride that's actually controlling inflammation and fibrosis, what is it? I already showed you that part of the equation is hepatic insulin resistance and glucose production. But the question then becomes, it must be some other site. Is it the adipose tissue? And this is exactly what we did in a study of about 40 individuals. And what we did was we did all those complicated studies, but in the blood we measured CD163, and CD163 is a marker of macrophage activation, and the macrophages in this case are in the liver. And what we were able to show is that macrophage activation parallels free fatty acids and lipolysis from adipose tissue. And the macrophage activation in the liver correlated with adipose tissue insulin resistance. And then in an in vitro study, we were able to show that if you take macrophages in vitro and you expose them to palmitate, then you get increased macrophage activation. So really the two concepts we're saying is that adipose tissue drives hepatic insulin deposition, triglyceride deposition, but the inflammation and fibrosis is driven by adipose tissue insulin resistance and also hepatic glucose production. And then using all of that data, many of you will know the ESSENCE data, which shows that you get both steatohepatitis resolution without worsening of fibrosis, and you get improvements in liver fibrosis with no worsening of steatohepatitis with a GLP-1 drug like semaglutide. So when you look at all of this data, there is adipose tissue insulin resistance and hepatic insulin resistance that are drivers of inflammation and fibrosis. And to summarize all of that data, the fundamental pathophysiology is increasing adiposity, resulting in adipose, muscle, and hepatic insulin resistance. Adipose insulin resistance drives inflammation and fibrosis, and hepatic insulin resistance and glucose production also drives inflammation and fibrosis. So if you're thinking about management, you need to target the underlying insulin resistance, weight loss, diet quality, exercise. We're now in the new world of GLP-1 receptor agonists and incretin-based therapies, as well as glucagon receptor agonism. And I know that saroglitazar is already approved in India, which is a PPA gamma agonist. Now, but the more recent data suggests that the GLP-1 receptor agonists have both indirect effects through weight loss and also direct effects through targeting inflammation. And looking at the glucose side of the equation, we need to have good blood sugar control. You need to have good control of your HbA1c and your type 2 diabetes. Yes, we also know that resmetirom and FGF21 analogs, which really target more distal aspects of steatosis and inflammation and fibrosis in the liver work. But fundamentally, if you really want to treat the whole person, you got to target the adipocyte insulin resistance with weight loss. So I believe we're on the cusp of novel treatment paradigms and pharmacotherapies for MAFLD and MASH that will be available in the near future. So thank you very much.
I think we'll take question and answers in the last. You can join us on the stage. Our next speaker is Ajay Duseja, Pharmacological Treatment of Obesity in 2025. Over to you, Ajay.
Can you just, sir, can you help me? Is the pointer working here? Yesterday it was not. Okay. Sure, thank you. So good afternoon, everyone. Again, at the outset, my sincere thanks to Akash and the whole organizing team for the kind invitation, and special thanks for making me part of the opening session of the APASL theme yesterday, and today again for the opening session in the Build 3. I bring greetings to all of you from PGI Chandigarh, and today he has asked me to go a little beyond hepatology. Management of an obese cirrhotic was discussed in the pre-lunch session today, so I'll be discussing the drugs in general which are with us, say in 2025 for the management of obesity. So before I go into the pharmacotherapy of obesity in 2025, let me just briefly take you that traditionally we have been, I'm calling it traditionally, why I'm calling it traditionally, it will come down to that. We have been calling it as the excessive fat accumulation in the body, typically defined by BMI, and for Asians we have a lower cutoffs for overweight and obesity in comparison to the Western population. This is the traditional definition of obesity. Quantum, overall, there has been the obesity prevalence has increased globally maybe 3 times since 1975, around 13 to 15% prevalence of obesity globally, and the figures may go up to 18 to 20% by 2030. There's a recent study 2 years back from ICMR, large number, 113,000 individuals, both in urban and rural population studied. The generalized obesity prevalence is 28.6%. And abdominal obesity, which is based on the waist circumference, is close to 40%. So these are the Indian figures. And if you want state-wise data, that is also available. And most of these urban states you can see are in red. Even in the rural area, Punjab, Chandigarh, we are in the red zone. And the projections are, really alarming as far as the obesity and all the metabolic complications are concerned. So having said that, as I said, we traditionally have been defining it by BMI, but there are certain, the limitations of using BMI for obesity. And the major one is that it overestimates adipose tissue in somebody who's muscular or has heavy bones, but we still will call it as obese based on the BMI, and it may underestimate inflated individuals. So people have been using waist hip circumference, waist hip ratio, and all that also to define better so-called the visceral adiposity. But if there are any postgraduates here in the audience, the MD or the DM residents, I think I'm quoting now 2 very recent papers. Both these papers have been published only last month. This is the Lancet Commission, which was probably laid down 4 or 5 years back, but the paper has come, as I said, only last month in the January issue, and they have kind of redefined obesity. So what they are defining now is that they're dividing them into preclinical and clinical obesity. So preclinical, clinical obesity, the BMI cutoff would remain the same, but if you do not have any obesity related symptoms or limitation with daily activity or organ dysfunction, they are calling it as preclinical obesity. The moment you start having limitation with the daily activities or organ dysfunction, and they have given a beautiful table there of defining organ dysfunction. As hepatologists, let me tell you, for mast cell, what are they calling it as organ dysfunction? So mast cell D or steatotic liver disease would be defined as obesity related illness only if it is associated with hepatic fibrosis, not otherwise. Similarly, for cardiovascular, everything they have given. So organ dysfunction, if you have, or there's a problem with daily activity, it is clinical obesity. Otherwise, everything else is filling it into preclinical obesity. Dr. Anup Mishra and his team has again come out with a recent paper again last month. This is published again in this diabetes metabolic syndrome. They have now said that the obese definition may be more than 23, and rather than calling it as preclinical and clinical, they are calling it as stage 1 and stage 2. Stage 1, again, no symptoms, no limitation of day-to-day activity, no organ dysfunction. The moment you start having organ dysfunction and day-to-day activities, then they're calling it as stage 2. So in general, I think if you look at here, the interventions you may or may not be doing for preclinical, but yes, therapeutic interventions are required if you have clinical obesity. Not further discussing further, let me take you to my topic, which is the pharmacotherapy, what we have today in 2025 for obesity. In general, the principles of management of obesity will remain the same, which means that the first step is nothing but the lifestyle interventions. The time will not permit me to get into the details of lifestyle interventions, and it doesn't come into the purview of my subject today. But if your lifestyle interventions are failing, then you have these three choices: pharmacotherapy, bariatric surgery, and bariatric endoscopy. Even if somebody is subjected to bariatric surgery and that the goal is still not achieved, you can actually use pharmacotherapy even after surgery also. So I think this is a broader and a very simple concept of that where to use pharmacotherapy. Lifestyle interventions are failing and you now want to go to another modality. Yes, pharmacotherapy is one of the modalities which you can choose. Now, what are the different anti-obesity medications which are available? For my sake, I have divided them into maybe one which are maybe of the first generation or the earlier drugs. For in this category, you have three set of categories, and all these drugs are approved by FDA for usage in patients with obesity, including the tirzepatide, which has recently been approved by FDA. So orlistat, which we know is a gastric and pancreatic lipase inhibitor, phentermine topiramide combination, any agonist or a GABA agonist, and naltrexone bupropion combination, which we know are the opioid receptor antagonists. These I would call them as maybe the first generation kind of drugs. But the newer generation drugs are these. These are either GLP-1 monoagonist, or these are used in combination with either a GIP agonist, which is a tirzepatide, or then they can have a triple, GIP, GLP-1, glucagon agonist, and various combinations are available. We will not be discussing drugs like this setmelanotide. These are, drugs for what we call, people divide obesity also into so-called syndromic obesity and non-syndromic obesity. So these are some of the drugs which are for syndromic obesity and which we will not be discussing. So I'll be talking only on the non-syndromic kind of obesity, which are, as I said, these are all FDA approved drugs which are there. So mechanism of action, as I said, the first generation drugs I already said, but when you're using these drugs, the GLP-1 with or without other agonists, they are basically targeting all these gut-related hormones, GIP, GLP-1, glucagon, amylin, PYY. And if you look at the actions here, all these drugs, whether it's liraglutide, semaglutide, tirzepatide, they all have both central action, CNS action, predominantly reducing the appetite and in decreasing your food intake, versus they also have the peripheral action. And the peripheral actions are occurring either in the stomach, which is, decreasing your gastric emptying, increasing the fullness, at the pancreas, increasing insulin and glucagon, or, increasing the energy expenditure at the level of, sorry. So, increasing energy expenditure at the level of the adipose tissue, and they can have certain other actions also. So as I said, you can have either plain GLP-1 agonists, you can have GLP-1 with GIP, you can have GLP-1 with glucagon, you can have GLP-1, GIP and glucagon, all triple kind of agonists which are available. So let's look at the efficacy of all these drugs. So again, as I said, I'm not really talking about these first generation drugs, orlistat, phentermine and naltrexone, because their efficacy, if you compare with liraglutide, semaglutide and tirzepatide, is obviously much lesser. But if you just focus here, which is typically the focus of our MASLD or steatotic liver disease, that you would require either a 5% weight reduction or maybe 10% weight reduction, then if you look at this tirzepatide, 91% 5% weight loss, 84% 10% weight loss. And similarly, if you look at the drugs like semaglutide, it's close to 86% and 69%. And liraglutide obviously is lesser, and these are also slightly lesser. So this is the, the kind of efficacy, but then the important thing is that how do you choose these drugs? Which one to use? The best efficacy is coming from the GLP-1 agonist. As I said, either alone, and tirzepatide, as I said, is a GLP-1 and a GIP-1 dual agonist. So these are some of the registration trials. I'll not be going into the details. And the registration trials for semaglutide are what called the STEP trials. And you had STEP 1, 2, 3 and various kinds of trials. And based on this, as I said, the FDA gave the approval to this drug semaglutide for use in patients with obesity, both in adults, and there's data even in adolescents also that this drug can be used even in adolescents also. Similarly, the registration trials for tirzepatide, which as I said is a GLP-1 and a GIP, are what called the SURMOUNT trials. And again, you had SURMOUNT 1, 2, 3, 4, 5. And again, based on the data on tirzepatide, as I said, this drug was also approved by FDA for patients with obesity. And as I said, SEMA again for obesity and for diabetes. Now the question is, now you have semaglutide with you, which is a GLP-1 agonist, which as I said is a very good, but then you have a dual agonist, which is GLP-1 and a GIP, which is, as I said, is tirzepatide. So which one is better? So this is a real life data of a very large number of patients where they compared this tirzepatide and semaglutide, and they found that yes, the tirzepatide was definitely better. But this was not head to head, this was a real life study. So now the company has now come out with the results of this so-called SURMOUNT 5 trial, and this was a head-to-head comparison between tirzepatide and semaglutide, and which says that the weight reduction with tirzepatide is close to around 20% in comparison to semaglutide, which is around 13-14%. So yes, tirzepatide is better. But then, as I said, now we have drugs GLP combined with glucagon, and the drug is called survodutide. Then you have a drug which is combining GLP-1 with GIP and glucagon, and the drug is called retatrutide. And so you have various combinations which are coming in, and looks like that the efficacy may further increase, and it may even go beyond what the efficacy we have for tirzepatide. The other additional advantage with GLP-1 agonist, again we have some data with tirzepatide or a GLP-GIP agonist also, is that it does help you in improving your cardiovascular outcome. Again, part of the STEP 1 trial, and for the cardiovascular outcome, the trials were called as the SELECT trials. And again, a very large number of patients, and they had this placebo-controlled data. And if you look at the cardiovascular endpoints here, they are lesser in the semaglutide group in comparison to the placebo group. So FDA has now approved this drug even as a prophylaxis for cardiovascular disease in patients with obesity and diabetes. So this is an additional advantage which semaglutide is giving you. Not only the cardiovascular outcome, now the GLP-1 data is coming in that it is also improving your long-term kidney outcome, again as a part of the SELECT trials. The SELECT trials were looking at your efficacy or the cardiovascular outcome, and now they have seen that it improves your kidney outcome, and not only kidney outcome. Yesterday I spoke on the neurocognitive decline in MASLD. GLP-1 is also improving your neurodegeneration. So again, I think so it is having a lot of extra adipose tissue or extra hepatic effects the GLP-1 agonist is having. So I think I'll be left with maybe just 1.5 minutes. So how do you choose? As I said, looks like in 2025, if you have semaglutide and if you have tirzepatide, I think these are the drugs of choices. Yes, you need to look at the age of the patient. You need to look at the comorbidity. If you have cardiovascular disease, diabetes, the choice is very easy. But the only one situation where you should not be using tirzepatide and GLP-1, that is if you have history of medullary thyroid carcinoma or pancreatitis or MEN2s. These are the three indications where you should not be using GLP-1 and the GIPs. Otherwise, I think these are the drugs of choice. I can't get into the details of using the other drugs because I'm a little short of time. So, but then, as I said, these look like so-called, people are calling them as silver bullets. Some people are calling it as magic bullets. But then there are some issues with GLP and whether mono or dual agonist. And one of them is the cost, availability. Rather, there was a shortage. And unregulated, people are using these drugs unregulated. So there are a lot of issues and GI issues, pancreatitis, and even, again, not directly attributable, but there was some media reports where people said that tirzepatide related deaths have happened. So I think all those issues, and so FDA is very, very clear that unless these are kind of approved, I think these drugs should not be used. Now, how do you, look at this issue of that, look at the cost? So one strategy which has been done is that you can use them, that initially use the GLP-1 agonist, and once the weight is down, then in the real life you can use the first generation drugs, and then that kind of weight maintenance can be done. So to summarize, since my time is up, as I said, obesity is a big epidemic, both in globally as in India, around 28% general obesity, 40% abdominal obesity. But I also gave you these two recent studies about preclinical and clinical obesity concept from India, stage 1 and stage 2 concept. And again, lifestyle interventions are the key, but yes, if they are failing, you can use the pharmacological treatment. Again, divide them into based on the comorbidities, diabetes, without diabetes, with cardiovascular, without cardiovascular. Cost is an issue. I have not discussed about the liver disease. Today, semaglutide and tirzepatide have the best efficacy. Yes, maybe you can start them on these drugs since the cost is a problem. Maybe you can maintain them with others, but we have a lot of other drugs which are in pipeline, which I said GLP-1 with GIP and a triple combination. I have also not discussed about the SGLT2s. So with this, I'll take this opportunity to invite each one of you to the annual conference of APASL, which will happen in August in Chandigarh, 7th to 10th of August. Block your dates and you're all welcome there. Thank you very much for your kind attention.
Thank you very much for that very informative lecture. It's our distinct privilege to call upon Professor Dept for the very much awaited state-of-the-art lecture on wheat, gluten and ATIs in health and disease.
Thank you very much. And thanks to Professor Shukla and Professor Sarin for this excellent conference and also the add-on in the BUILD conference. I will try to give you a very quick overview on an important nutritional factor, wheat and components that in some patients can cause disease. There is no real conflicts of interest, just PI on clinical studies. So we have several categories of inflammatory wheat sensitivity, which are summarized here, which I will shortly discuss. We have celiac disease and the classical wheat allergy, which is an immediate reaction, which is rare, at least for the GI tract. And we have a novel so-called type 2 wheat allergy, which is very prevalent in patients with irritable bowel syndrome. And we have the phenomenon of ATI sensitivity. ATIs are TLR4 activators in the gut. And there's an entity that we call non-celiac wheat sensitivity, which comprises number 3 and number 4. So what is celiac disease? Little warrant, it's intestinal inflammation caused by gluten from wheat and related cereals like barley and rye. Prevalence worldwide is pretty high, in the average 1% in most countries of the world, of course India included. And it's a Th1 classical inflammatory T-cell reaction to gluten coming from the food, gluten peptides. And the clinical pictures nowadays range from no or few symptoms to severe diarrhea and malabsorption, the so-called classical symptoms. Patients often have atypical symptoms, extraintestinal mainly, complications of long-standing undetected celiac disease is raising autoimmunity, cancers that are otherwise very rare of the small intestine, like intestinal adenocarcinoma and intestinal T-cell lymphoma. There is a relatively clear diagnosis now in active celiac disease by increased autoantibodies to the body's own enzyme tissue transglutaminase, or TG2. So it's one of the best tests, or maybe the best test in internal medicine. And the therapy appears simple, but it's not simple. A strict gluten-free diet. And this is important to mention. Celiac disease is highly associated with other autoimmune diseases, especially of the thyroid, type 1 diabetes, rheumatoid diseases, and others, including multiple sclerosis. So had we known this a while ago, that there is celiac disease and other inflammatory wheat sensitivities, we would have rewritten our European fairy tales, which you might know too. What is the practice recommendation for celiac disease? You must know it's the chameleon of internal medicine. Patients might not have intestinal symptoms, but mainly extraintestinal symptoms, including unexplained transaminitis. Recommendation is simple. You do the validated test for autoantibodies of the IgA, the mucosal class for transglutaminase 2. You also test for IgG antibodies in those patients that are IgA deficient. And if you have unclear and complicated cases, which are pretty frequent, like refractory celiac disease, non-responsive celiac disease to the gluten-free diet, you should consult an expert center for expertise. And one expert, Dr. Macharia, we have here. However, we need supportive pharmacological therapies, which I will explain in this slide. So this is very easy to avoid, classical gluten-containing food. But it must be known that essentially all refined foods usually contain traces of gluten if they are not declared gluten-free, because gluten additions are important for taste and consistencies of several foods. This results in the problem that maintaining a strict gluten-free diet in everyday life, in social or business life, is very difficult for patients, and the perceived quality of life can reach that of those on hemodialysis, which is pretty heavy. And a minimal gluten ingestion can cause inflammation and symptoms in a significant proportion of patients despite a strict gluten-free diet, because minimal amounts cannot be easily avoided. And that means that a supportive pharmacological therapies in those patients is needed, and the patients desire such a pharmacological therapy. So what about the pathogenesis? It's one of the best explained pathogenesis in an immune-related disease. So here you have the intestinal lining with intestinal epithelial cells. You have the lumen on the top. You have the lamina propria below, which harbors the largest immune system of the body, the lining around the whole intestinal wall. You might have some mucosal permeability changes, increases, that occur anytime in healthy and diseased patients, and then more food stuff comes in, and normally the intestine is primed to sense food in low amounts to declare them by active tolerance as not harmful. if that system is overcome by large amounts of the antigen or the trigger and a certain genetic predisposition, patients can get celiac disease. So what happens here, gluten peptides get into the lamina propria. They can react with the body's own autoantigen, the enzyme tissue transglutaminase, which is produced by many cells, mainly non-epithelial cells, and released into the extracellular space, where it can react preferentially with gluten peptides due to the unique structure of the gluten peptides. And then the patients, 30% of most populations that carry HLA DQ2 or DQ8 as antigen-presenting molecules can present the gluten peptides on macrophages, dendritic cells, and B cells that have DQ2 or DQ8, especially the modified gluten peptides after contact with tissue transglutaminase. These cells then themselves activate an innate immune response. A predominant factor is IL-15, but specifically they activate T cells to expand in terms of gluten-specific T cell responses. They also activate other cells that cause mucosal remodeling, and that's what you see in active celiac disease, that there is villus atrophy of the upper small intestine, the resorptive area, and a crypt hyperplasia. And in addition, these activated T cells promote B cells to produce IgA, mucosal autoantibodies to the body's own enzyme tissue transglutaminase, which is involved in the pathogenesis by potentiating immunogenicity of gluten. To date, there is no approved therapies. There have been trials with glutenases that effectively cleave luminal, still biologically active gluten peptides. Gluten is not very well digested by enzymes in the GI tract. There is tight junctional stabilizers, a study with SIRT6 agonists, which is also an interesting molecule for liver disease that can close tight junctions. There is tolerance induction, especially by nanoparticular therapies in phase 2 clinical studies. These nanoparticles are filled with gluten epitopes and go either to the spleen or to the liver to induce tolerogenic T cells. There is attempts, especially in our little company, to block gluten antigen presentation on DQ2 and DQ8, which is not necessary for life because 70% of the population do not have DQ2 or DQ8. And there is transglutaminase 2 inhibition because that enzyme potentiates the binding to HLA, DQ2, and DQ8 of the gluten peptides. And I will just quickly refer in a couple of minutes to this enzyme. I will skip this. This enzyme, in a way, modifies gluten peptides, as you see here in the one letter code. It modifies a glutamine residue, a Q, to become an E residue, a glutamic acid residue. So it acidifies one position in the gluten peptide, which is then presented in the antigen binding pocket of HLA DQ2 or DQ8, which prefers certain charges of amino acids. I don't know why it went back again. And then it causes an improved fit into the antigen binding pocket here. And this improved fit increases. I don't know how to enlarge this now. So it's a little bit difficult if you don't have something manual. Okay, so I will go on. So we were here, and when this gluten peptide now binds much better because position 6 now is a negatively charged amino acid due to the body's own enzyme, then the T cell receptor can bind much better and the T cells can be activated better than without this modification by the enzyme. So I just show you data of a phase 2 clinical study using a small molecule that inhibits the enzyme tissue transglutaminase. It's a study that has been published. Patients in remission were challenged with 3 grams of gluten for 6 weeks, and then patients received 40 per group, either 3 doses, escalating doses of the small molecule inhibitor, a tablet, a pill, or placebo for 6 weeks, and the primary endpoint was villus atrophy. Secondary endpoints, PROs, patient-related outcomes, and other inflammatory markers. And this study has been published a few years ago. It was successful, as you can see here, from left to right. Right is the placebo response, single patients before and after challenge. You see there is a decrease in villus height on the right side, placebo treated as expected, and there is a dose-dependent normalization of the villus height to crypt death. And if you look at another marker, intraepithelial lymphocytosis, this also completely normalized from left to right versus the very right placebo group where these inflammatory lymphocytes increase. Also the PROs improve. The red is the placebo group during the challenge, and all the other groups are the dose-dependent treatment groups. And you can see that up to week 6, there is a decrease in the PROs specific for celiac disease in the untreated challenged patients versus the treated ones. And now, since we are also a liver conference, there is also or was a normalization of slightly elevated liver enzymes, a bystander hepatitis that you can also see in Crohn's disease or ulcerative colitis with drug treatment. So this is a summary. This inhibition addresses a central pathomechanism of celiac disease, highly specific. An oral pill is available. There is a dose-dependent prevention of histological damage. And there's now 2 phase 2b clinical studies, one that has just been finalized in a real-life scenario, patients that do not respond without any challenge to a gluten-free diet, 400 patients, 100 centers, and another study with a very minimal gluten challenge and 3 doses of the drug versus placebo. Now we come to number 2. These are classical food allergies, classical foods, prevalent in children, less prevalent in adults. These patients have usually IgE autoantibodies, positive skin prick tests, and immediate type reactions. There's another type of food allergy, what we call eosinophilic type 2 food allergy. We collected patients with irritable bowel syndrome. The prevalence in most countries is between 10 and 15% of the population. And when you put these patients on a 3 days of a fasting diet without significant allergens, olive oil, and rice or potato, then 70% of these patients improve significantly, pointing to food triggers of IBS. And these patients, with exclusion of any other kind of inflammatory diseases, were then challenged by the duodenum for very common foods: milk, soy, yeast, and especially wheat. And what you can see here, after injection of fluorescein to make under magnification endomicroscopy barrier changes visible, is an explosion into the lumen of fluorescence fluid and shedding of villus epithelia on the right side. And you can quantify that, and I will not go into much detail, but just show you that patients who were put on the exclusion diet of the identified food improved within a year significantly, essentially to normal levels in terms of their complaint scores. So there are very common foods as a very common major trigger of IBS symptoms, and patients cannot identify these because clinical reactions are protracted by up to half a day. So they might eat something in the evening and have complaints the next day. So what do? You inject fluorescein, you have your standard endoscope with a larger channel, and you have a probe. You have the provocation, standardized provocation solutions or suspensions of your common foods, usually in 30 ml. For example, you inject milk for milk proteins. No reaction, there's no fluorescence with a 1,000-fold magnification visible. Here you have a wheat suspension, and you see a picture like that. It's like day and night when you have such immediate type reaction with a confocal endomicroscopy in a live scenario. What you can see in these patients, during the challenge, they have an increase histologically of intraepithelial lymphocytes, a mild MARSH 1 lesion, and they have an increase in eosinophilic cationic protein in the duodenal fluid, and they have a change in the tight junctional proteins within 30 minutes of a positive challenge, occludin and claudin 2, and they usually have atopy in their family or atopy themselves. And the food reaction is predominantly against wheat, higher than against milk, soy, and yeast, and in rare cases against egg and other classical food allergens. So it's very common, and it's related to intestinal barrier defect that communicate also with other organs. So if something with the barrier is wrong, inflammation increases, a vicious cycle of more barrier defect and inflammation occurs, and you have more influx of potentially dangerous components or potential the allergens that all of a sudden become allergens because too much gets into the immune system of the lamina propria. And so you get a vicious cycle. So IgE negative type 2 food allergies, prevalence is very high. Recommendation is put the patients on a basic diet for 3 days. If they improve, they have a problem. You can tell the patients without endomicroscopy that wheat is a major trigger, milk comes second, and then perhaps after a few months you can reintroduce small amounts of the allergenic food, and the reconstitution of the mucosal barrier is very important. Last, in a couple of minutes, is ATI sensitivities. ATIs are non-gluten proteins from wheat and related cereals. They stimulate the LPS receptor TLR4. They are highly resistant to intestinal proteases. There are several species, and they represent about 3% of the wheat proteins compared to gluten, which is about 80%. And we and some others have published a lot of papers on the basic mechanism on experimental animal models of ATI sensitivity and 4 clinical studies subjecting patients with chronic disease to wheat or no wheat diets. So what happens here? These ATI proteins do not get digested. They are highly compact and resistant to proteases. Especially with barrier defects, they are taken up. In a healthy gut, they don't do anything significant, a mild stimulation of inflammation on myeloid cells that express TLR4. However, when these cells are stimulated, they can migrate out of the gut through the bloodstream to external tissues, where they can fuel ongoing T-cell reactions, especially in autoimmunity. And we have shown that experimentally and in part clinically for a lot of organs and diseases up to the lung, up to the brain, and also in terms of the metabolic syndrome. So I will skip that. That's multiple sclerosis. So ATIs act as immune adjuvant when ingested with the food. The effect is dose dependent. So small doses of wheat don't do much. And there is no necessity of a strict gluten-free diet or ATI-free diet when you have patients with active autoimmunity, for example. We have done several clinical studies as depicted here, small groups, wheat versus no wheat in the diet, even in NASH. Now a clinical study that has been published start of this year. Give me 1 more minute and I'm done. This is a study that refers to a common, very difficult to treat liver disease, PSC, in conjunction with ulcerative colitis. And these patients were treated with or without wheat for 3 months in the diet. And V2 is baseline and V6 is end of treatment. These are bioptical assessments of inflammatory cytokines by PCR at V2 or V6 in the rectum on the right side, or the sigma on the left side. And you can see that with a wheat-free diet in orange, these inflammatory markers decrease. When we look at the best currently available fibrosis marker for liver, that's thrombospondin 2, this went down in those treated with a wheat-free diet from left to right, the same also with TSP4. and also many other inflammatory signatures improved with a wheat-free diet. Okay, I summarize. We can assume ATI sensitivity, non-celiac wheat sensitivity, that mainly increases autoimmune diseases, but also metabolic diseases. Recommendation is a largely wheat-free diet, not completely necessarily, and we have still other IITs, for example, in rheumatoid arthritis. This again is the summary. If you want to read about it, there's an English book, Wheat Syndromes, that might affect 10 to 15% of your patients. And there is, of course, many people involved, support, and this is part of my group, but you might recognize there is 4 people from India working on either liver disease or on intestinal barrier defects and wheat-related diseases. Thank you very much.
Thank you, Professor Supan, for it. Why don't you join out here? Supan, join out here. We had time for questions. Dr. Jacob, would you join out here, please? I think we have 3 wonderful talks today, and all 3 very, very important and very relevant. We start with one question with Dr. Supan, that you just showed that the ATI is a protein present in wheat, that can also lead to PSC. That's very interesting. That's very, very...
So based on this data, both animal experimental as well as the proof of concept study in 16 patients, either on wheat, same patients, or not, the PSC consortium in Europe, which is composed of 100 PSC centers, is planning a trial now, putting the patients on a largely wheat-free diet. The nice thing is that you don't have to put the patients, like in celiac disease, on a 100% wheat-free diet or gluten-free diet, but it can be 90 to 95%. It's a dose-dependent inflammatory activity.
That brings to the question that of all non-communicable diseases like celiac disease, the diet induced. Many other diseases like PSC or other autoimmune disorder, the diet may be an autoantigen, which can induce autoantigen. Therefore, this knowledge is so important that diet could be a factor. We know obesity is diet, but who knows systemic lupus or multiple sclerosis is also induced by some dietary antigen. So any question? Audience, any question?
Yeah. So I've got 2 questions. Excellent presentation. One question is to Dr. Jacob George. You said that insulin resistance is the key driver to NASH as well as NAFLD. But isn't this too simplistic? Because the main disease of insulin resistance is type 2 diabetes, but all patients of type 2 diabetes don't have NAFLD. Only about 70% and only 40% of them have got NASH. The second thing, those patients who do not have diabetes, when we measure their insulin resistance through HOMA, everyone is not insulin resistant, but still they have NASH. So this is my one question, and second I would ask Dr.
So I think in answer to your second question, every patient, if they've got type 2 diabetes or pre-diabetes, will have insulin resistance if you do a clamp. The problem with the HOMA is it's a very rough test. And in fact, HOMA was actually developed as a population-based study. So you can compare 2 populations and say one is more insulin resistant than the other. And it typically also measures hepatic insulin resistance because it's based on a fasting glucose. Whereas at an individual patient level, the reproducibility of a HOMA is actually very low. So for individual patient studies to be truly able to say you're insulin resistant or not, you need to do a clamp type study. And what was the first question?
All diabetics don't have NASH.
Yeah.
If it is due to insulin resistance.
Yeah. So all diabetics, if you do an MRS, you will have hepatic steatosis. But they may not get inflammation and fibrosis because that depends on the extent of, as I showed you, adipose tissue, insulin resistance, and free fatty acid delivery to the liver. And the triglyceride itself is not toxic. It's the metabolites of the lipid that are toxic: ceramides, sphingolipids, and DAGs. So we're not actually measuring that, we're just measuring triglyceride. So in a diabetic that doesn't get steatohepatitis, they'll always have steatosis, but their equilibrium between the triglyceride doublet and the signaling molecules that cause inflammation may be different. And then the hepatic insulin resistance also varies. And again, that may have something to do with the gluconeogenic enzymes and their responses, particularly PepsiK.
Okay, thank you. Second question to Dr. Ajay. So we have now new definition of obesity, and we are going away from BMI. So at one side we have, we are not depending on BMI itself or the weight itself, but rather the fat. But most of the trials results from GLP-1, they have actually measured the weight loss. So do we need to reanalyze how much was the muscle loss in those? Because muscle loss is an important consequence of even GLP-1 agonist therapy. So how much is the muscle loss and how much is the fat loss with these new drugs?
Dr. Ashish, the entry point in the newer definition, both by the Lancet Commission and even by the Indian group, is still the BMI. You have to define obesity by BMI, but then once you have defined obesity by BMI, then they are further characterizing it as clinical and preclinical. Preclinical is that you are obese by the BMI category, but then you don't have any organ dysfunction and the obesity is not affecting your daily activities. But then once you start having organ dysfunction and it starts, disturbing your daily activities, then it becomes a clinical obesity. But the entry point is still the BMI. Even with the Indian, newer paper by Dr. Rupeshra, still the entry point is BMI, but then they have taken a BMI of 23. I don't know how they've done that, but still then they divided them into stage 1 and stage 2. The entry point still is BMI. Now coming to the second, and we know the limitations of BMI obviously are there. The second question you're saying is that how much is the weight reduction and how much is the muscle loss? I think that's a very important point. I'm not aware of the full data, but yes, there's a lot of muscle mass which gets lost with a lot of these GLP-1 agonists which are mono or even dual or triple, and that does contribute to their weight loss. But then as you heard from Dr. Jacob, GLP-1s, they act in two ways. There are no GLP-1 receptors in the liver, but then they do have some anti-inflammatory activity and they act by reducing weight loss. Both, some of it is by muscle loss and some of it is by the adipose tissue loss. So both losses are happening, but yes, muscle loss is also happening.
I think just to actually make a point on that, in regards to the muscle loss, there's now very, very good physiological data that says that the muscle loss does not correlate to the use of the drug. So whether you lose 10 kilos from a GLP-1 or a triple agonist or bariatric surgery, or you decide to lose weight with lifestyle intervention, the muscle loss percentage, which can be up to 20 to 30%, is exactly the same. So people who are obese with a high BMI, just to carry their body, they actually have a lot more muscle than when they're thin. So the muscle loss, there's no difference depending on the type of strategy you use to use weight loss, including lifestyle. The second point to mention is that I think with the BMI categories that they talk about, clinical and preclinical, I think you've got the danger, and presumably they won't get into the same syndrome, where you classify this and then you decide it's preclinical, it's not giving you symptoms, therefore you don't need to treat, which is just crazy. If we actually said that about aortic stenosis 20 years ago in med school, we learned that when you actually get a syncopal episode from aortic stenosis, you treat it. Now we actually treat it as soon as you get echocardiographic changes. And similarly with obesity, even if it's preclinical, you've got to treat it early.
I think with that, we'd like to thank all the three speakers. Wonderful topics, wonderful presentations. Thank you, everyone. Thank you.
Thank you, speakers and chairpersons.